Hello, this is Robert Lee, and this is a brief video on salvage radiotherapy following radical prostatectomy. Brief agenda. First, we'll define biochemical recurrence, describe the natural history of biochemical recurrence following radical prostatectomy, and then look at the phase 3 trials addressing the addition of androgen deprivation therapy to postoperative radiotherapy. So, it turns out that the definition of biochemical recurrence after radical prostatectomy has changed over time, as you might expect. In the early days of PSA, the level of detectability was 0.4 nanograms per milliliter. The test became more sensitive, and the consensus around 0.2 developed. We now have newer, more sensitive tests, and although there hasn't been a consensus paper yet agreeing to 0.1, certainly many are moving in this direction. This is a relatively straightforward analysis done by Dr. King, which looked at the success rate of salvage radiotherapy according to PSA level prior to salvage radiotherapy, and to no one's surprise, he found that the likelihood of success decreased as your pre-radiotherapy PSA increased, and in general, with most cancers, earlier treatment is probably better than later treatment. And he suggested for every 0.1 nanogram increase in PSA, the likelihood of radiotherapy succeeding falls by about 4%. So the natural history of biochemical recurrence has become very clear from a unique institutional experience. This comes from the Johns Hopkins group, which is known historically as being a center of excellence for urologic cancer. And this is what is called the Pound paper now from 2 decades ago, which looked at a group of about 2,000 men, of whom 300 or so had developed a biochemical recurrence, which at the time was 0.2 nanograms. And they found that in this group of 300 men, the median time to the development of distant metastasis was 8 years, and that distant metastasis was related to postoperative Gleason score, the time to biochemical recurrence, and that biochemical recurrence soon after radical prostatectomy was more indicative of developing distant metastasis, and finally, more rapid PSA doubling time was associated with increased risk of distant metastasis. As with many things, though, in prostate cancer, there's an enormous heterogeneity. This is a paper from Steve Friedland, formerly at Hopkins and Duke, now on the West Coast, looking at prostate cancer-specific survival. And what you see here is, depending on the time to recurrence, the Gleason score, and the doubling time, the results are very, very different. And if we take this example of a man who has a Gleason score of less than 8, and his recurrence is more than 3 years after surgery, and he has a long doubling time, his 15-year estimate of being free of prostate cancer death is 94%, or stated in another way, 6% risk at 15 years of dying of prostate cancer if you have a long doubling time, a low Gleason score, and a long disease-free interval. Alternatively, if you have a high Gleason score and a short disease-free interval, even if your doubling time is long, there's about a 1 in 3 chance that you'll die of prostate cancer in the next 15 years. And you can see that if your doubling time is quicker, the numbers fall off quite rapidly. This is a statement from another paper from that same group looking at those men who developed a biochemical recurrence. 2/3 of men with a biochemical recurrence will develop overt metastasis if they're left untreated, and a majority of these will die of their disease. Now recognize this is the Hopkins group. They're very well selected patients for radical prostatectomy, so these are young men who are likely to live 20 or 30 years, and in their experience, watching these men without treating them, 2/3 of them will develop metastatic disease, and of those that do develop metastatic disease, most of them will die of their prostate cancer. And this was caused the Hopkins group to change their practice from what had been observing these patients until they developed clinical evidence of metastasis to recommending early salvage radiotherapy. So now we'll look at the randomized trials in the salvage radiotherapy space. This is RTOG 9601. Patients had to have a detectable PSA following radical prostatectomy. They're randomized to prostate bed radiation alone, which was the standard arm, to the experimental arm, which is prostate bed radiation plus 24 months of an anti-androgen, in this case bicalutamide, 150 milligrams. Published now about 3 years ago, overall survival was improved in those men treated with bicalutamide, a 5% roughly improvement in overall survival at 12 years. Prostate cancer mortality was cut in half at 12 years with the addition of the bicalutamide. The authors did provide a forest plot looking at various subgroups, and they noted an interaction. That is to say, those patients with a low PSA at the time of radiotherapy, less than 0.7, in fact, no effect of treatment of the bicalutamide was observed, and all of the effect of the bicalutamide seemed to be in those men with higher PSAs prior to radiation. So that the treatment effect differs according to the pre-radiotherapy PSA level. Now, recognize this is an unplanned subgroup analysis and is hypothesis generating. This same study has been looked at in another analysis, a secondary analysis published just this year. If you look at those men whose PSA was above 1.5 when they started their salvage radiation, these seem to be the men that benefit the most. A 50% reduction in mortality associated with bicalutamide, and the absolute risk reduction is 25% for these men with high PSAs. Alternatively, if you look at the men with PSA less than 1.5, there really doesn't seem to be much of an effect. Now remember, this is an unplanned subgroup analysis, hypothesis generating, that certainly suggests that the majority of the benefit from bicalutamide is in those men with higher PSAs. These authors went one further and looked even lower at the lowest PSA level, less than or equal to 0.6. A good number of patients, almost 400, very little evidence for a treatment effect. So at the higher PSAs, 9601 shows a benefit to bicalutamide. At the lower PSAs, the benefit is not evident. The second study that addresses the use of androgen deprivation in salvage radiotherapy that's been published is the JETUG study. Very similar schema to RTOG 9601, detectable PSA following radical prostatectomy. Was originally designed to see a difference in 10% at 10 years in overall survival as the primary endpoint. The other thing to point out is These are patients whose PSA was required to be undetectable after radical prostatectomy and then become detectable. Radiotherapy alone is the standard arm, 66 gray to the prostate bed. 15% of the men were treated to the pelvis, which was up to the physician's discretion. The experimental arm was the same radiotherapy with 6 months of, in this case, a GnRH. Primary endpoint was progression-free survival that is shown here. At a good long follow-up of 112 months, there's a benefit to the group that received Gaserelin. Now recognize that progression-free survival when there's hormonal therapy in one arm and none in the other is probably not the best endpoint. They looked at metastasis-free survival as well, and there seemed to be an effect there in that the Gaserelin showed a benefit in metastasis-free survival, absolute difference of 6% at 10 years. These authors looked for the interaction that had been reported in 9601, and they did not use a specific PSA cut point, but they divided patients into a low risk and a high risk subgroup, and really no evidence of any interaction for any of the variables that were looked at. So what are we left to conclude? This is the NCCN guidelines from 2020. The patient with a detectable PSA following radical prostatectomy, assuming they have negative imaging for distant metastasis. Treatment recommendations range from observation to salvage radiotherapy to salvage radiotherapy plus ADT. And I think the reason that you see this dramatic range of treatment recommendations relates to the underlying natural history. There are some men who likely will never have a problem. Those older men with a long disease-free interval, with a low Gleason score and a long doubling time, those men are very different than young men with high-grade disease, lots of high-risk features, and a short disease-free interval. We still have lots of remaining questions to answer in the post-prostatectomy setting, including total dose of fractionation, should we treat the pelvis, and the role of anti-androgens and chemotherapy, and these will be addressed in a subsequent video. Thank you.